I forgot to hit record on my camera before I started lecture this morning, and fortunately my camera shuts off after 5 minutes if it's not recording, so it gave me an indication that I had done something wrong. I just picked up in the class where I was in the lecture, started the camera, picked up with the class, so I thought I'd record kind of the intro to the vertebral column and add it to the front end of this. So at about the 5 minute point, this is going to switch over to classroom lecture. So this is chapter 9, but the vertebral column, the function of the vertebral column is to protect the spinal cord, support the trunk, and provide the muscles for attachment. And I've mentioned in class would essentially be an earthworm if we didn't have a vertebral column. So it allows us to get upright. Our muscles and our bones just basically are levers. So we have projections on our vertebral column that help us to move. Those are processes that stick out of the back and out of the sides. So it forms along with the skull, the axial skeleton. It's centered for the most part mid-sagittal plane. Once we get into scoliosis, it may deviate from that a little bit. And it is located in the posterior trunk, so it's not in the middle of the at the coronal plane. It's posterior to the coronal plane. So we have 33 individual bones, and some of those will fuse. The portions that are in the pelvic cavity will fuse into two separate portions. Those will be the sacral segments and the coccyx. So 24 true movable vertebrae, and we'll talk about the different specifics of the different types of vertebrae, cervical, thoracic, and lumbar vertebrae. So they're divided into 5 groups essentially. So you have cervical, thoracic, lumbar, sacral, and coccyx, coccygeal vertebra. And again, the sacral and the coccyx, or the sacrum and the coccyx fuse. The sacrum has 5 vertebrae, and the coccyx has anywhere from 3 to 5. And those vertebrae will fuse into two bones that are completely immovable. I think it's about where we picked up. I think I saw this slide and I kind of explained the intro to it, and I'll do that again. But when you're describing the vertebra and the curvatures in the vertebra, you need to understand that there are 2 types of curves. There's primary and secondary curves for a total of 4 curves, but there are 2 types of curves, primary and secondary. So a primary curve is a curve that you're born with, and a secondary curve develops over time after you stand upright and you start to have pressure applied vertically onto your axial skeleton. So the ones that you're born with are the pelvic curve and the thoracic curve. So the cervical curve, the curvature in your cervical vertebra, develops after you start walking, or at least you spend more of your time upright, the head providing weight that then causes the vertebra to bow. Your lumbar spine is the same way. So lumbar spine, if you ever see a spinal series on a child, there really is no curvature in very young children. There really is no curvature in the lumbar spine. It's not until we get upright that the rest of the trunk provides weight on the lumbar spine, you develop that curve. So you're gonna have questions on the curves from really kind of 4 different directions. So a lordotic curve is anything that kind of leans backwards. Kyphotic curve kind of leans forward. So you think about a patient who's kyphotic, and what that means is that they have an abnormal curvature where it looks like they're slouching. So that's kyphotic curvature. So that the top and the bottom are more anterior than the middle is. And a lordotic curvature goes the other way around. So the top and the bottom are more posterior than the center. So I mentioned in class that, just word association, the word cave, just taking the con out of it and just going with cave. Cave is basically a hole or a hollow space in a mountain where you can walk into it. So concave, think of concave as being something you can go inside of. And then another word association that I use is, when somebody flexes their muscle and the muscle bulges, we call that flexing. And so convex, vex, flex, a rhyme is not really as close a word association as what this is, but that's kind of a bowing outward. So what we're going to have is lordotic curvatures and kyphotic curvatures. And then your questions may ask you if that curvature is concave or convex. So, and it may even break it down a little bit further and say, is it concave anterior or is it concave posterior? So that's what the curvatures look like. We've got, again, lordotic curvature that would be convex anteriorly, concave posteriorly. Now this is thoracic, this is lordotic, or kyphotic rather, and it is concave on the anterior side, convex on the posterior side. Now we're down to the lumbar spine, and it is concave on the posterior side, convex on the anterior side. And finally, we get down into the pelvis, and it is concave on the anterior side, convex on the posterior side. This is just a frontal view.
The curves, right? So what you've got are lordotic and kyphotic curves. What was lordotic chest X-ray?
Angled up.
Angled up, or patient was leaning back, right? So what that gave us, a kyphotic or a lordotic chest X-ray, is any kind of curvature that kind of leans backwards. Okay. The opposite of kyphotic, if we had a patient with multiple thoracic compression fractures, the patient came to us kyphotic, right? So we've got a natural kyphotic curvature in a T-spine, and when they have those multiple compression fractures, they get more kyphosis, right? So kyphotic curvature is like in the T-spine. And so what we've got is we've got a lordotic curvature. The C-spine has a tendency to lean back a little bit. Once, the pressure of the head starts bearing weight on the C-spine, it has a tendency to develop a lordotic curvature. And kyphotic curvature is in the T-spine. Then we get again back down to the bottom. We've got the L-spine. We've got a lordotic curvature, and then in the pelvic sections we've got again kyphotic curvature. All right, now it's also going to ask you, the test questions will also ask you about concavity and convexity. All right, so just defining the words. You're looking at a mountain, and there's a hole in a mountain. What do we call that hole in a mountain that you can walk into?
Cave.
It's a cave, right. So word association, concave is something that goes in, and convexity is a thing. You can word associate that too, and you make a big muscle, what are you doing? Flexing, right, you're flexing. Okay, so a little more of a stretch there, flex, vex, right, but it rhymes. So convexity bulges outward. So concavity goes in, convexity goes out. So if we're looking at the C-spine sections, what we have is on the anterior side, what does it do? Does it bulge out or does it bulge in? It bulges out, right. So on the anterior side, the C-spine is convex, right. The T-spine is concave, it goes in. The L-spine is convex, and then the sacral segments are concave, right. So that's the anterior portion. Now look at it from the posterior portion. So since we're concave or convex on the anterior side of the C-spine, that naturally would mean that we would be concave on the posterior portion. Since we're concave on the anterior portion of the T-spine, we're going to be convex on the posterior portion. You see where this is going. If we're convex on the lumbar portion, then we're going to be concave on the posterior portion. And then down in the sacral segments, or the pelvic segments, we're concave on the anterior portion, so we're going to be convex on the posterior portion. Okay, so all of those are testable questions regarding the curvatures of the spine. So two primaries, that would be the thoracic and the pelvic sections. The other two are secondaries, and you got the concave, convexity, and lordotic and kyphotic curves. So there is one other curve that we got to concern ourselves with, and that is lateral curvature, abnormal lateral curvature. So that's what we refer to as scoliosis, And pathologic scoliosis tends to be something that you're born with, and the demographic is usually young women. Okay, so that diagnosis, I don't know if they still do this in school, but used to, when I was in school, everybody got this test where you would stand in front of somebody and bend over and they'd look at your spine. They still do that. Okay, good. And what they're looking for is scoliosis. They're looking for, once you bend over and you kind of arch your back or bow your back up, you kind of see the spine a little bit better, and you can see if there's any kind of curvature, right? So that's scoliosis, abnormal lateral curvature. And even in this, you've got primary versus secondary curvature. The pathologic curvature is your primary curvature. Your body tries to recenter yourself over your trunk. So you see, you got the coccyx here, and if you go straight up from the coccyx, where is the top of the C-spine? Centered. Pretty close over it, right? So the pathology, so to speak, is the deviation away, and then your body tries to recalibrate itself, and you've got a primary and secondary curvature. Now, we're not going to ask you which one's primary and which one's secondary. It's just for your understanding as to why the scoliosis can be so bad. And that's some pretty, at least upper moderate scoliosis. I've seen patients that, if they could straighten up, they'd probably be 2 foot taller than what they are, right? So that's some severe scoliosis. We had one patient one time, she couldn't even stand. We had to do a scoliosis series on her. Somebody had to hold her up. So that was a joy. So a couple of other things. One is that you can also have what they refer to as compensatory scoliosis. This is not on a test. This is just FYI. You're going to get to a point where you're going to start really looking harder at x-rays. So you look at a chest x-ray and you see this usually is more prominent in men who do manual labor. So you're seeing their spine go up, and then right at the top of the T-spine, it kind of deviates off to one side. And that's what we refer to as compensatory scoliosis. It's not really scoliosis, it's overdevelopment of the muscles on one side of the spine. So they're always tight, and they have a tendency to make the spine bend in that direction. So you're carrying around an 80-pound toolbox, for 4 hours a day, then the muscles on that side have a tendency to overdevelop hypertrophy as compared to the ones on the other. I'm sorry, I just said that exactly backwards. The muscles on the opposite side have a tendency to overdevelop because you're pulling right against that big toolbox. So where you see this is, again, in people who do manual labor where they're carrying heavy stuff, and generally whichever hand that they carry stuff in, and it doesn't always have to be the primary hand, the dominant hand, but whatever hand that they have a tendency to carry stuff in most, the muscles on the opposite side have a tendency to overdevelop, and then you shoot a chest x-ray on them and their T-spine goes up and it makes a slight shift, okay? It's not truly scoliosis, it's what we refer to as compensatory scoliosis. The other thing is that if a patient has multiple compression fractures in their spine, those fractures can introduce some sort of scoliosis, and that demographic is usually osteoporotic women. I don't think my mom was, she never mentioned it anyway, that she had scoliosis when she was a kid, but later in life, you could see definite deviations. I think she developed multiple compression fractures. So scoliosis, again, diagnosed most of the time in young women. You do see some men with scoliosis as well, true scoliosis, but the other two are developed over time. All right, so you got separation between each one of the vertebrae with the intervertebral disc, and the disc, it provides a function and keeps things separated and keeps the joint spaces from, being stacked on top of each other. So where people start to have issues with arthritis, and a lot of times it comes with the compression of some of those discs. So the disc is kind of like a jelly donut. Think of it as a jelly donut. You get the jelly donut out of the counter, and it looks great, right? But if you squeeze it, what happens? jelly comes out of it, right? So what that looks like is this right here. This thing is supposed to be representative of a ruptured disc. So if you hear somebody say, I got a slip disc, the disc doesn't slip, it ruptures, okay? So it ruptures and it bulges out, and if it bulges in any direction, you may lose some vertebral height and you may get some arthritis, and the joint spaces back here, the joint spaces are actually in the posterior portion. Facet joints, you may have heard people say, I got to get a facet joint injection. That's what they're talking about, is those back there. We'll get to that. So you might get some arthritis, you might get some bone on bone there, but where the real issue becomes an issue is where that rupture starts to push on one of these nerves, and then it pushes the nerve into a bone, right? And now you've got some pretty severe pain in some cases. You may have some peripheral numbness, tingling in toes and things like that. So the disc, it doesn't tend to rupture just right away. It ruptures incrementally. So you can think of the fibrous outer portion of the disc as being layers of things that'll tear just a little bit at a time. Ever seen anybody tear a phone book? Somebody say yeah, I think. Okay, so how do they do it? How do they do it? They just grab the phone book like one of your textbooks and just go to town, right? I don't know, they fan the pages out a little bit so that what they're doing, yeah, it's kind of trickery. Watch them closer next time. But what they do is they fan, it's always got to be a soft cover book. You're never going to see anybody tear a hardcover book, but they fan the pages out so that while they start it, they're just tearing a few pages at a time, and then once they get the whole thing started, it comes apart. I'm not going to say easily, but it comes apart. Think of your fibrous outer portion of the disc kind of being like that. You know, sometimes you can rip all the way through, but most of the time it's a wearing thing. So you start the tearing on the inside, and it tears and it tears and it tears a little bit more, and then you get that nucleus pulposus that oozes out and it mashes on your nerve, and then you've got problems, right? So that's your disc. You got the annulus fibrosus as the outer portion, nucleus pulposus is the inner portion. A herniated disc just means, you know, and slip disc means the same thing. That's that goo is coming out and it's mashing on a nerve. That's the problem. If they have a problem with it, it's mashing on a nerve. What's that?
How do they fix that?
That's a good question. They can remove the disc and put bones in there, and it could be donor bone or it could be, you know, bone from your own body. Sometimes they'll take the bone from the iliac crest and put it in there, put plates and screws, and you know, I'm not saying that's going to fix it, but you know, hopefully it will. And then it is generally because, you know, you're not using proper mechanics. I am the world's worst about that. I'm going to not lift with my knees. I'll lift with everything but my knees. I have a whole lot of choice. My knees hurt too. All right. So typical vertebra, you got two main parts. You got the vertebral arch. That's the back portion, and then the body is what, you know, you're probably most familiar with whenever you look at an x-ray. Now an x-ray looks square, but it's obviously not, right? It's more round. And then through the vertebral arch, we've got the vertebral foramen. That's kind of the culmination of all the bones that form the posterior arch. And that's where your spinal cord goes through. So you got the body, you got the vertebral foramen. Coming off of the body, what we've got are what we refer to as pedicles. All right, so again, word association. You got something that you want to display and you're really, really proud of it, you put it up on a pedestal, right? Pedestal, pedicle. That's, you know, the part that holds up the body, okay? So it comes out and it joins up with what we refer to as the lamina. I'll give you another way that they also kind of deal with slip disc here in a bit. But anyway, the lamina is here, right? And where the pedicle and the lamina come together, you got two things. One is a facet, and it's one half of the joint at that level. I'll tell you about the other half in a minute. So we got the facet, and then we've got where they come together, it comes out into the transverse process. And where the two lamina come together, we've got the spinous process, and that's a, dinosaur bone that's sticking out of the back of your neck or, your upper back. So those are the parts of the vertebra. Now where this two-dimensional image doesn't really show the contours, what we've got then in the joint spaces is a facet. We've got a facet on the top and we've got a facet on the bottom, and they come together to form what we refer to as a facet joint. So the upper portion facet articulates with the facet of the vertebra directly above it to form just a skinny little joint space like that. It's called a facet joint. It's also referred to as a zygapophyseal joint. Big long word, spelled pretty much like it sounds, ZYG apophyseal joint, zygapophyseal joint. All right, so, and it also forms between the two unions, it forms this vertebral notch, and that's half of where the nerves come out. So you got this big hole that's going to eventually become what we refer to as the intervertebral foramina, and that's where the individual nerves come out, okay? So vertebral foramen, you've got where the spinal cord goes through, but you have to have some place for the vertebra to, or the nerves to come out, individual nerves, and that's what we're going to call the intervertebral foramina. Okay? Now also, we got specific indicators of what type of vertebra you're looking at. All right, so every type of vertebra has a different appearance to it. Obviously, the sacrum and coccyx, they're going to be fused. Coccyx is going to be real small, sacrum is going to be a lot bigger, but it's going to be like 5 fused vertebrae together. It looks like a portion of the pelvis. But C-spine, T-spine, and L-spine also have unique issues with them, and I'm going to get to them individually. But this one, I'm going to tell you, is a thoracic vertebra, and I'm just going to float that out there, and then we're going to see if you can figure out why that is a thoracic vertebra, or if you'll remember it when we get to it. Okay, so the vertebral foramen, intervertebral foramina, don't confuse those two. The intervertebral foramina is where the nerves come out. All right, so you got 2 pedicles, 2 lamina. You got the articular processes, 2 on top, 2 on bottom, spinous process. All right, so since we're doing C-spine today, I'll say this about C-spine. Spinous process on C-spine vertebra have what we refer to as bifid spinous process. Bifid means forked, right? So you got a lot of motion in your C-spine, right? More than any other portion of your spine. You can turn your head and you can really get some hyperflexion, hyperextension. So, if our spinous processes completely come together, whenever we completely flex our neck, then you're going to be a little bit mobility limited, right? But if we've got just a little bit of a cut in our vertebra, then we can get just a little bit more flexion. Does that kind of make sense? So think of your cervical vertebra as having that, just so that we can get a little bit more flexion. It's got a bifid or forked spinous process. We don't see that on any other vertebra. There's another thing that we're going to get to here in a minute that also indicates a cervical vertebra, but that's one of the indicators we're looking at as cervical vertebra, is that it has a bifid spinous process. So we've already been through all this. All right. So here's typical cervical vertebra. It's got a body. It's got that bifid spinous process. And it also, though, has a transverse foramen. So that's for your vertebral artery to go through, okay? So you're not going to see that on any other vertebra. So if you see a diagram on any test at any point, and it asks you what type of vertebra is it, on this diagram, and it has bifid spinous process, really good chance that's a cervical vertebra. And if it has a hole in the transverse process is tiny and it's got a hole in it, then it is definitely a cervical vertebra. Right, so those are two indicators that you're going to have when we're looking at a cervical vertebra. All right, so in addition to that, we've got three that are somewhat different than the rest of them. Okay, C3 through C7 are pretty uniform. Each one gets a little bit bigger than the one directly above it, but you know, if you had, let's say, number 3 and number 5, you could make the mistake of saying I got number 3 and number 4. You know, if somebody just handed you two bones, very, very similar. But C1 and C2 kind of have a little bit of a symbiotic thing going on. One is, you know, the construction of one is supportive of the construction of the other. All right, so we're going to call C1 the Atlas. Now, who is Atlas in Greek mythology? Carried the world. Yeah, he's that guy that's got the globe on his back and he's on his knee, right? So, what on your body most represents a globe? Yeah, your head, right? So that's the bone directly below your head is the atlas, okay? It's carrying the support of your head. And then directly under that, we've got what we refer to as the axis, that's C2, okay? So C2 has a very large body, and on that body, it's got this thing that sticks up, all right? The book describes it as a tooth-like projection off the anterior portion of C2. So the body sticks up through C1, okay? So what's the part of your car that the wheels turn on?
The axis.
Well, it's axle, right? So again, word association, axle, axis. The axis is the thing that sticks up through the atlas so that your head, almost all of the, you know, the rotation in your skull comes from that joint between the axis and the axle. Axis and the axle. The atlas and the axis, okay? That's where most of the rotation comes from. So C1, C2, very different from all the other vertebrae. C1 has no body. It's just a ring of bone, or if it has a body, it's tiny. You know, you're going to look at it in a second, you're going to say that, you're going to call that a body. It doesn't have much of a body. C2 has a great big body, but coming off of that body, you've got that tooth-like projection, and that is your odontoid process, or dens, we'll also refer to it as. C7 is big because it has, or different because it has a very long spinous process. So it, with every vertebra, you know, you got, there's a slow transition from C-spine to T-spine, T-spine to L-spine. What I mean by that is the upper portion of the T-spine looks a lot like the lower portion of the C-spine. Lower portion of the C-spine looks a lot like the upper portion of the T-spine. Now apply that to the L-spine. The upper portion of the L-spine looks a lot like the lower portion of the T-spine, and vice versa, right? So in that, what we can have is what we refer to as transitional vertebra. And what transitional vertebra are vertebra that take that a little bit to the extreme, okay? In the C-spine, where we see that is sometimes, and you know, full disclosure, I've never seen this in clinical practice, but it's testable, and it's in every registry review book, which means that it's a good chance it's going to be on a registry. The transitional vertebra in the lower portion of the C-spine is a condition that we refer to as cervical ribs. So what you'll see is that the C-spine actually has, C7 actually has ribs on it. They're not going to be full ribs, they're going to be what they refer to as rudimentary ribs, so they may be short. But the problem is that the C-spine's not set up to have ribs, right? So the nerves are wanting to come off in a specific direction. And with those ribs there, in a lot of cases, what the patient will have is some sort of neuropathy, tingling, you know, some sort of irritation of that nerve because it's trying to go around that rib. So, you know, the patient may come in for a C-spine series or CT of the C-spine or whatever, and it's not really incidental finding because it's causing a problem. It's just a surprise that the patient has transitional vertebra. It's got, the patient has cervical ribs. But normal to all C7 is that long spinous process. It's got a very long spinous process, and you can actually feel it. So if you reach back on the back of your neck, that knot, what you're actually feeling is the soft tissue on top of what we refer to as a vertebral prominence. That's C7, the spinous process is C7. So everything below that is pretty much the same length, or it's similar in length enough that you don't feel a separate thing. All right, so here's C1. So C1, the odontoid process is supposed to be this thing right here. It's actually larger than that, but what we've got is transverse atlantal ligament right back behind it. Now, a couple of things about C1. Once we get into imaging, we can have broken anatomy without really, is clinically broken, without really having a broken bone. Okay, so one fracture of the C-spine where we see this is that if that ligament is ruptured, then there's nothing really holding the atlas in the front of the vertebral canal. Okay, there's nothing holding it there in the vertebral foramen. So what we may have is C1 slides a little bit further anterior than what it should be. And I'll show you what that looks like here in a little while, and it'll make sense as to why we take our lateral C-spine in the way we do. Okay, so the main things on the C1 that you got to know is that the odontoid process goes up through it. You've got the transverse foramen. You've also got these facet joints that articulate with the base of the skull, and that's where you get your rotation. And then, you've got the posterior arch and all that. It doesn't really have a spinous process. It's got that little, point. Doesn't really have a body. It's got that little point. But it's mainly just a ring. We can also have a fracture, and we'll get into fractures here in a little bit, of the atlas as a whole. And I don't remember if I mentioned this when we were talking about the pelvis, but anytime you have a bone that's like it's got a great curvature to it, and especially if it's a ring, you can't break it in just one place. If you were to take something that's relatively fragile and it's a ring, and you break it, it's not going to just snap in one place. If it's brittle, it's not just going to snap in one place. So if we break C1, that's what we refer to as an axial loading fracture. The patient fell from a height, landed on their head, and they broke their C1. It's going to be broken in multiple places. There's a specific view that we're going to do to diagnose that. That's if you've done a C-spine at all. Anybody? Or been in a room with C-spine? Yeah. So the open mouth odontoid, that's where we see that. And I'll point that out to you here in a little bit. All right, so there's your axis. Again, big body. You got the dens or the odontoid process, both mean the same thing. C7, we already talked about that. All right. So, procedural guidelines, a few things here. Most of these are no surprise. We're going to shoot everything except for the lateral at 40 inches. Lateral, if at all possible, we want to get to 72 inches. And I'll talk about that whenever we get to it. But most of your views in C-spine will want to get at 40 inches if at all possible. 72 inches for the lateral, if at all possible. Make sure that you collimate, make sure you apply the proper collimation, make sure that you understand what the proper collimation is, all right? But also, if the patient comes to you and they've got a cervical collar on, don't take it off. It's an ER doc's job to assess the patient, and if the doc feels like the collar can come off the patient, then the doc needs to take the collar off the patient, Also, if the patient is wearing any kind of jewelry, earrings, necklaces, that really needs to come off if at all possible. If that means you got to take the collar off to take the jewelry off, you don't take the collar off. You leave the jewelry on the patient. Now, if you're working with technologists that are taking it off, I'm not criticizing them because I did it myself. but you don't do it, okay? You don't take the collar off. If you work with somebody who does it, then, you know, that's their thing. You just stand back and let them do it, all right? Certainly if they take the collar off, they should not be repositioning the patient. You know, if they shouldn't, because the patient sometimes will come in a collar, and the collar's not on them at all. You know, the collar, if you've ever looked at the collar, it's got a platform where your chin is supposed to sit, right? And it immobilizes your neck really, really well. Sometimes your patient will come in like this, all right? So the technologist should not be taking the collar off, extending their chin and putting the collar back on. You know, if they pop the front of the collar off, it should just be to remove whatever. All right, so, but you don't do it. So if it can come off of the patient, if the patient doesn't come in secured in the collar on the backboard, then, you know, you need to remove all that stuff. All right, ambulatory patients, you can shoot them upright or recumbent. My experience, all of the views, with the exception of lateral, I get better results with the patient on the table. I just do. So your mileage may vary. If you're getting good images with the patient upright for the AP and the obliques and everything else, you know, do what works for you. So trauma patients, though, totally different animal. Going to be cross tables and all that. So 10 by 12 is what we're going to be using collimation size. And really, it could be smaller than that, more like 8 by 12. You collimate in just a little bit. Okay. So, and of course, collimation is your ethical responsibility, and I hammer on that. But it also does go into image quality as well. So how does it apply to image quality? Well, if you're using a 10-inch, 10-inch lateral collimated field, you're going to be putting direct exposure on that image receptor, and that's going to go into the calculation of how your image is going to be displayed, how it's going to affect your contrast, how it's going to affect your S number, index number, whatever. So it can make a difference. Make sure you call it. Skin level. Okay. All right. All right. So breathing instructions we'll talk about on each individual view. So what we're going to talk about are a couple of different APs. We're going to talk about AP Fuchs, and that's for the dens itself. We're going to talk about the open mouth odontoid. We're going to talk about the AP. Most people are just going to call it AP. It's going to be AP axial. We're going to talk about the lateral. That's a Grandy method. And then we're going to talk about hyperflexion, hyperextension. And if it's easier for you, just remember flexion and extension. Just remember flexion and extension. Hyperflexion and hyperextension just seems forced, right? So then we're also going to talk about anterior and posterior obliques, and we're going to talk about a lateral as well. All right, so I'm going to skip over this and go directly to the open mouth odontoid. All right, so you're reading through your Merrills, and it gives you, positioning indications, how to position for your C-spine views. I'm going to tell you, almost all the views of the C-spine involve what we refer to as the occlusal plane. So the occlusal plane is the plane of the teeth, right? The plane of the teeth and how it relates to your mastoid process. So your mastoid process is this knot right behind your ear, okay? That's your mastoid process. Y'all okay over there? Yeah? All right. This seemed kind of giggly. But the mastoid process is not right behind the ear, okay? So the occlusal plane is a plane that goes across the teeth from the upper incisors and aligns to that knot, all right? Problem with lining all that stuff up is you have to have the patient show you their teeth, all right? So you got that number going on. And then you got the patient in a collar, right? And the collar comes up to about here. So where is that mastoid process in relationship to the collar? It's down inside of it. So how are you gonna feel where the mastoid process is if they got a collar on? You gotta mash your finger down inside the collar, right? All right, so let's say you've got something, you've got a sore neck, maybe a sore head. You definitely have a sore head because you've been laying on that hard wooden, backboard. And this thing is tied around your neck and somebody starts jamming their finger down into it. What are you gonna do? You're gonna run from them, right? So you got a potential C-spine issue. Is that a good idea? No. Okay. So then, I'm gonna bring my bag. It's got my markers in it. So I'm gonna have to use this. All right, so take this, you got your mastoid process and your teeth. Is that relatively aligned? I can't see.
Yeah.
Yeah, okay. So if I go up from that, you see where that point is right there? You see what that thing right there is? Are they pretty well parallel to each other? Yeah, okay. That's what we refer to as a canthion. That's where the nose attaches to the face, a canthion. And the line that would go from the canthion out to the ear hole, we refer to that as the external auditory meatus. And that would be the acanthomeatal line. Okay, so the acanthomeatal line parallels the occlusal plane. So if you're lining up for, any, with the exception of the Fuchs, any C-spine view, the acanthomeatal line needs to have a relationship to something, okay? So we've got here, they've got his chin extended a little bit too far back, but if his acanthomeatal line was, vertical, then what we would have is it would be perpendicular to the image receptor. Can I see that? So what we're gonna do is if the patient's not in the C collar, we're gonna extend the chin till the acanthomeatal line is gonna be vertical and perpendicular to the image receptor, okay? So we extend it until that is vertical. And how we can do that is we can put our crosshairs directly on his acanthion and open up the collimation until you see that dark line of collimation that's coming down from the side of his mouth. Okay, so go ahead and line up to your image receptor. Move the patient until the crosshairs are right on his acanthion. Open that up until you can extend the patient's chin or flex the patient's neck to get the acanthomeatal line perpendicular. That's very important at this point. Collimate, and then move the patient. Don't stay lined up there, but move the tabletop until you tell the patient to open their mouth as wide as they can, and you shoot right through the middle of the open mouth. And what you're trying to do is you're trying to put the teeth, which are right here, directly on the occipital bone, which is right back here. You're trying to line those up perfectly, okay? So now imagine, let's see if I can get out of the way. Our odontoid process is right there, let's say. Now if his chin is tucked, his chin goes that way, and his teeth are right here. If his chin is tucked, what's gonna happen to your ability to see the odontoid process right here? What's gonna be on top of the odontoid process? The teeth, right. So when you look at your image, if the teeth are on the odontoid process, what that means that you need to do if you're gonna repeat is go back and extend the patient's chin a little bit, right? Now reverse that. What if you've got the chin extended too far back? The occipital bone now is right here. The teeth are gonna go that way. What's gonna be over the odontoid process? Occipital bone, right. So what you wanna see is you wanna see the teeth and the occipital bone superimposed just pretty much perfectly. And then that's how you're gonna assess it. Sometimes you're gonna get a patient that you just can't get. Either way, no matter what you do, you've got perfect superimposition of the teeth and the occipital bone. It's still over the upper portion of the dens. So what do you do? Again, I don't have any of the stuff I need. Anybody got a disposable wooden pencil? Got everything. Okay.
Anything there?
I'll owe you a pencil.
I have a whole pack.
Okay. All right. So we kind of talked about this when we were talking about, somebody has a rod in their leg, right? If somebody has a rod in their leg, the rod's probably not going to break. Where's the break going to occur? Right where the most secure meets the rest of the anatomy, right? So we've got the odontoid process. We've got the odontoid process in as much as the odontoid itself, which is just this portion right here. Where do you think that is most secure? Way up here? Right across the middle? Way down there?
Right at the base.
Right down at the base, right. So what if you don't get the very tip of the odontoid process? Could it be a problem?
Yes.
Yeah, it could. What if you don't get the base of the odontoid process? Could be a much greater problem, okay? So where is it most likely to fracture? Way up here at the very top? Or way down here where it's held in place most securely? Right, so there's my odontoid. This is rest of C1. I reach up and, where's it gonna break? Right at the base, right, okay? So you wanna get a good open mouth odontoid, right? Because you don't want to send a patient home with a fracture right across the base of the odontoid process. If they have a fracture somewhere else, it's probably not going to be as dangerous, right? But we do have a view for that. That's where we're going back up to the fuchs, okay? So the fuchs is a little bit different. The only thing that it shows is the dens. All right, I've got to turn off some of these lights so I can see this a little bit better. Okay, so that's the dens. This is a foramen magnum. Foramen magnum means big hole. That's where your brain stem comes through your skull. But notice you don't really see the base of it real well. You know, in the odontoid process, it can actually fracture down into the body a little bit more. All right, so you would definitely miss that fracture that dips down into the body more with just doing a fuchs. So if you don't see the upper portion of the odontoid process, then you can shoot a fuchs. The fuchs is the only view of the C-spine that does not involve the acanthomeatal line. So what you're going to do is, if the patient's not in a collar, you can extend the patient's chin back far enough until the mento, this is what we refer to as the mental point. So, when you're thinking hard, what are you doing? Yeah, right? Even the sculpture, the thinker, where's his hand? Right there, right. So that's your mental point. So the mentomeatal line is a line that goes from the mental point out to the EAM. So what with the fuchs, what we're going to do is we're going to extend the patient's chin back far enough to put the mentomeatal line perpendicular to the image receptor. Okay, and then we're going to put our central ray just below the chin, and that's what we should see. Okay, so when do you try to get a good open mouth odontoid?
When you look at the base.
Every time you shoot a C-spine series. Every single time you shoot a C-spine series. Okay. What if you shoot it and you miss position and you can't see the odontoid process? Just shoot a fuchs and say be done with it? No, you go back and you get a good open mouth odontoid. Because what's the fuchs going to show you? Just the top. Just the top. All right, so let's go back to the open mouth odontoid and look at the image on it. That's what we should see. Okay, this is pretty close to perfect. There's the teeth, there's the base of the skull. You see this little dip right there? That's part of the occipital bone. So we got a little bit of superimposition over the very top. Certainly you can go and take a fuchs to show that if your doc's really upset about it. But what we want to see on the open mouth odontoid is we want to be able to visualize the entire odontoid, and these are what we refer to as the lateral masses, okay? Now back to that axial loading fracture. The patient fell, usually construction, you know, they fell from height or something heavy, bricks or something got dropped on their head. Suddenly C1, which is not a very big bone, has a lot of weight mashing down onto it, and it doesn't have a disc underneath it to give it any kind of cushion. Then what'll happen is that your C1 can break. That's your axial loading fracture. If it's a curved bone, it's going to fracture not just in one place, but multiple. And what's going to happen then is that the lateral masses in where we don't have a fracture, lateral masses of C1 should line up with the lateral masses of C2 pretty closely. Okay? So if you've got that fracture though, if you've got, and I'm going to stop saying axial loading, is also referred to as a Jefferson fracture. So with Jefferson fracture, what's going to happen is the lateral masses of C1 on both sides are going to be projected outward from C2. Okay? Now, going back up to the fuchs, and I'm doing this for a reason. Going back to the fuchs, where do you see the lateral masses C1 and C2?
You know?
You don't. You don't, right? So two of the most important fractures of C1, C2 are diagnosed on the open mouth odontoid. And how many of those are on the fuchs? Neither, right? So I used to rail about the fuchs and talk about how useless it was and it should be outlawed. It shouldn't be a part of any protocol anywhere. And then I kept getting in trouble by my lab instructor. So I'm not saying that the fuchs is useless, because it does have a use. You know, if you want to see that portion of the odontoid process that you're never going to break, you can see that. Okay, but imagine this. You know, you're a good person. You start hanging around with really bad people. What eventually happens to you?
You turn bad.
You turn bad. So yeah, I'm not saying the fuchs is bad, but I'm saying the fuchs hangs out with bad people, right? It's just, get a good open mouth odontoid. This is a feel-good film for the very tip top. So if Goldie asked you if I said it was, useless, your answer is, he said, no, it's not. It's not useless. It just hangs out at Useless's house every single weekend, all right? So get a good open mouth odontoid. So that's my fuchs soapbox. Open mouth odontoid, acanthomeatal line, shoot through the middle of the open mouth. Fuchs, mentomeatal line, shoot just below the chin. All right. So AP, they're just going to refer to it as AP in clinicals, but it's really AP axial. Your central ray angulation is going to be 15 to 20 degrees cephalic. Okay, so the common sense portion of this class is how many cervical vertebrae do you have?
7.
7, right. So what's in the middle of 7?
3.5.
3.5, right. But each vertebra gets a little bit bigger as it goes down, so compensating for that increased size, when we go from top to bottom, C4 is right about where we want to put it, right at the thyroid cartilage, all right? So right through the Adam's apple, make sure that you open up enough that, you're going to get, you're not going to see C1, C2, but you're going to include enough that, you're going to see as much of the upper C-spine as possible, all the way down to about T2, T3, okay? Remember, you have to see adjacent anatomy to make sure that you've got all the anatomy that you want to see. In other words, you can't just shoot from C1 to C7. You have to see a portion of T1 to make sure that you don't have some sort of fracture of C7, T1. All right? So central ray, 15, 20 degrees. And the difference there is really, what position, body position do you have a patient in? If you're upright, you got a greater lordotic curvature. You need greater angulation. So you're 20 degrees if you're upright. If you're laying down, gravity's pulling all the way across your C-spine, you only need the 15, okay? 15, 20 degrees, depending on the patient's body position. And, full disclosure, that 10 degree, or that 5 degree difference ain't really gonna make all that much of a difference. So, if you see somebody shooting an AP with a 20 degree angulation with the patient laying down, it's not worth the fight, right? It's not gonna make that much of a difference. All right, so that's what it should look like. So if it's a C4, that'd be C3. Notice you don't see C1 or C2. Occipital bone's gonna be covering it. We've got views to see C1 and C2, 8 views to see C1, C2. That's your open mouth contour. And then we've got, you know, T1, T2 down here as well. This thing right here is what, well, that's the
Spinous process?
spinous process, yes, thank you. Should be in the middle of the vertebra, or it should be in the middle of the spine. So what we're seeing there is the spinous process of the spine that's directly underneath it. Okay, so it should be in the disc space of the vertebra that's directly underneath it. So if it's in the vertebral body, you're either over-angled or under-angled. And the other thing that you can look at is these two things right here. You don't have to take this down, but they're what we refer to as the uncinate processes. So these uncinate processes, if they look like horns, that means you over-angled. If the body looks like it's crushed, that means you're under-angled. Okay, so those are two things you're going to look for. Where is the spinous process? Is it in the body or is it in the disc space? If it's in the disc space, you're probably good. If you did some kind of crazy angulation and you over-angled to the point where this was here, then your uncinate process is going to be really, really long. It's going to look like horns. Okay. So lateral C-spine is probably the most important view of the C-spine. I'll just go ahead and say it is the most important view of the C-spine. Pretty much every fracture that you're going to have in the C-spine is going to be demonstrated on a lateral. It might not be ideal for all of them, but it'll show every one of them. So it's very, very important to get a good lateral. Unfortunately, it's also the hardest one to get a good lateral from C1 all the way down to T1 because of the shoulders. Now notice though how high the collimation is. I mean, your C-spine ends like right here, but our collimation goes all the way up pretty much to the top of the ear. There's a reason for that. I'll show you here in a minute, but make sure that your collimation extends up to pretty much the top of the ear attachment, way up pretty close to your temple, okay? All right, so top of the ear, 1 inch above the EAM, C4 is going to be in the center. If the patient can do it, you know, have the patient stand upright, have them take their hands, have them put their hands behind their back and join their hands together, and then have them reach for the floor. And what's going to happen when they do that is it's going to rotate the shoulders back and down as far as they can go with it. It's important to get those shoulders out of the way. A lot of our subluxation is the type of fracture where one bone slides on top of the other are going to be C6, C7, C7, T1. Okay, so it's important to get as much of the lower C-spine as possible. So have them reach back. Also, with them upright, you're more likely to get C7, T1. So have them reach back, extend the elbows, reach for the floor, taking a big deep breath, blow it all the way out, and then make your exposure at the end of exhalation. Also, they've kind of mispositioned this guy. Look at his acanthomeatal line. It's more like acantho earlobe line, right? The problem with that is that your C-spine is right here, and what happens if you tuck the chin is you wind up putting the mandible over the anterior portion of the C-spine. If you're using that acanthomeatal line, it needs to be parallel to the floor. If it's parallel to the floor, then it's going to extend the chin enough to keep the mandible from being off the anterior portion of the C-spine. Also, the other tendency is to, you know, once they do this number, they go, ugh. Okay, well, the problem here is that what you do is you take the spinous processes and you compress them, and you also potentially put the occipital bone over the posterior portion of the C-spine. Okay, acanthomeatal line parallel to the floor. I missed that on the AP. If you put the acanthomeatal line perpendicular to the image receptor, then you get the most portion of upper C-spine as well. Okay, so acanthomeatal line parallel to the floor, join the hands together, 72 inches now. Because notice where our image receptor is. It's not just right up against the patient's neck, right? Yeah, I don't have my book. It's not just right up against the patient's neck. It's, his shoulder is on the wall bucky. So how far away is his neck from the image receptor? Yeah, it's, good 10 inches or so. So we have an increase in OID. How do we overcome an increase in OID and the magnification and loss of sharpness of recorded detail because of the increase in OID? Increase SID. So we're going to shoot this at 72 inches if at all possible. I kind of played around with this when I was working heavy trauma load. I thought, 72 inches was good, 10 feet had to be better. It really wasn't. So 72 inches is adequate. The extra 3 feet didn't really do anything, 4 feet didn't really do anything except for, increase the heat on my x-ray tube. So 72 inches, it also at 72 inches versus 40 inches, what you're using is more of the center of the central ray, okay? So the beam at 72 inches is more horizontal as opposed to being divergent, right? So you're less likely to project the lower portion of the C-spine into that downside shoulder. Very important to get 72 inches. And I'm kind of beating this to death because what you see in a lot of cases is that on trauma situations, people will shoot their lateral at 40, just for convenience. You're gonna get a better result if you go to 72. If your room is set up where you can get 72, even in a trauma situation, back up to 72 inches. You're gonna have to watch the nurses because they're gonna zip right in between the patient and your x-ray tube. Yeah, that's.
So it's saying the SID is 60 to 72. You need to know
No,
that, or
72.
72.
Just 72,
Okay.
yeah. I think the 60 is because some trauma rooms just won't let you get 72. I've worked in those, but if at all possible, 72 inches, yeah. Oh, that's all right. Okay. All right, so this is what we see, and then, I hate this image, because it doesn't show me what I want to see. Let me come out of this for a second. Oh, no, that's not good. There. Okay, so you've got a spot on your sphenoid bone. We're going to get into this next semester, but because our image doesn't show it, I thought I'd bring it up here. All right, so this is lateral skull, okay? And so you've got this spot on your sphenoid bone. This right here, you see that U-shaped thing? That's what we refer to as a sella turcica, okay? And we're going to get into this next semester. The sella turcica coming off of the back of the sella turcica is what we refer to as the dorsum sella or the clivus. You see that line right there? This image is a little bit high contrast, so we can't see it all the way through to the odontoid process, but that clivus should point right to the tip of the dens, okay, the tip of the odontoid process. So why do we center so high that we've got all the way to the top of the ear attachment, all the way up to the temple? So that we can include the sella turcica. Well, why is that important? Well, we need to assess. We need to look at that clivus and see if it's pointing to the odontoid process. If that ligament is torn and C1 is a little bit anterior and probably the rest of the C-spine, C1's probably not going to slide all by itself, but if it's pointing posterior to where it should be pointing, that indicates that ligament is ruptured. Does that make sense? So what you don't want to do is limit your collimation to that. You want to open up your collimation enough so that you can see the sella turcica, so that you can make that assessment. Hey, you're not going to make that assessment, but the doctor can make that assessment on that clivus and whether or not it's pointing to the right place, okay? So this is kind of hard to see as well, but can you kind of see where you got a shadow coming up from here? Okay, that's a posterior portion of the odontoid process coming off of C2. So if we've got a fracture of the odontoid process, and you can just barely see the odontoid process, but if you've got a fracture of the odontoid process, you could probably, hopefully, maybe see that on the lateral. Okay? Subluxation. Subluxation is sliding of one vertebra on top of another. Hangman's fracture is an example. It's an extreme example of a subluxation. What you have is subluxation of C2 and C3 with a fracture of the posterior arch. Okay? We can also assess soft tissue indicators if we've got a fracture. So can you see the airway here? See that airway? All right, so this is what we refer to as a prevertebral fat stripe. If the patient has a fracture, it's going to cause significant swelling of that fat stripe, and what we're going to see is the airway is going to be pushed way out here. You're not going to see that on the AP, the odontoid, or the fuchs. You're only going to see that on the lateral. And a final type of fracture is what we refer to as a teardrop fracture. And teardrop fracture is a small fracture shaped kind of like a teardrop off the anterior, I think inferior portion of the spine. And it looks insignificant, one of the most unstable fractures of C-spine. The reason it's unstable is, okay, you remember talking about Massenet fracture? Okay, apply Massenet fracture now to the C-spine because you have a syndesmosis that holds all these things together. And what happens is you get a rupture of that syndesmosis and you have a highly, highly unstable C-spine.
What's that internal decapitation?
Oh, okay. Internal decapitation occurs at the atlanto-occipital region. So that's way up here. So yeah, thank you. I meant to bring that up. And I've got a slide later on that kind of runs through all those. It just lists them. But yeah, internal decapitation occurs whenever the fracture between the base of the skull and C1, you know, you've got total dislocation there. That's just ugly to look at because you got a gap between the C-spine and the skull that's maybe an inch or two. We had a image one, it's probably down in a lab somewhere, and it was probably a toddler, not in a child seat, bounced around in a car. There was a gap of about 4.5 inches. It was massive. It was nasty. So, you know, I know most of y'all are pretty young, no kids. Get a car seat. Get a car seat. You know, if I see you in Walmart just putting your kid in an adult seat, I'm gonna say something. You know, even if I don't know you, I'm gonna say something. I'm gonna tell you what I think about you. So, yeah. Okay, so any question on lateral? Good lateral is very important. So one more thing on lateral. Let's say you're in a trauma situation and you shoot the lateral and you get down to C7, but you can't see T1. And we'll take a break after this. So what you can do is you can pull on the shoulders, providing the patient doesn't have a fracture of the humerus or a fracture of the shoulder or anything like that. You can grab the patient's hands and you can pull them down. Okay, so in that case, somebody has to be in the room with the patient while somebody pulls and somebody outside making the exposure. And here's my recommendation. Have one person pull both shoulders. Okay, don't have one person pull one shoulder, one person pull another shoulder. Because what's gonna happen is that you're gonna have two people that are gonna have totally different pulls, right? So let's say you got one person pulling with 80 pounds of pressure and one person pulling with 30 pounds of pressure. What's gonna happen? Yeah, they're gonna do this, right? So where you need them both to go down, you need this situation to happen. What you're getting is this situation. And it defeats the purpose at best and makes it worse more likely. Okay, so one person kind of laying across the patient's legs, pulling both arms with equal pull. That'd be my recommendation for pulling. So what you need to see is from, you know, C7, T1. So C5, C6, C7, can you see T1? Not really. Not really. So when we get back, I'll tell you how to deal with that. Let's go take a little bit of a break.